Welcome, everyone. I'm Will Sanchez. This is the man, our orthopedic surgeon, the sports medicine specialist, Dr. Grant Garcia, that apparently is busting my chops because I just have a cute little knee here. He's like, step up your AI game because he's got Dr. P's whole book back there. Listen, Garcia, man, I'm telling you right now, we're not doing this for 60 minutes. All right. Let's just cut the chase. Anyway, how are you? What's going on? Talk to me.
I'm good. It's finally sunny in Seattle, so that's a rarity here. We're taking advantage of it fully. So things are good. Busy, usual. Excited to have our guests. Really excited to talk about something, a little more of the non-operative side of things too, but in different operative as well. So it'll be a good, interesting topic people talk about, because as surgeons, we love to talk about surgery, but surgery is not always the answer. So it's a really good idea to have a conversation about this. And this is the thing I get a lot in my office. Patients come in, they don't want a knee replacement. They want to talk about alternative options. So this will be really good. And from an orthopedic surgeon, which is great. So I'm looking forward to talking about our guests and everything else.
I agree. And when you talk about surgery, we like to talk about recovery. Let's talk about our folks at the Recovery Shop and Mike B.
So big shout out. I've gotten a lot of traction with this. I've had multiple doctors ask me about it because they're interested. They get the same thing I get. I just had a doctor a couple of weeks ago call me about this. He said, my patients are asking for more. They want nutrition. They want newer things for post-operative. And this allows us as physicians to offer to our patients. And it's kind of a one-stop shop. It's really nice too. And a benefit that I found is the patients you don't have to go through your list of things for 10 minutes in the office and recommend things, right? It's all there already for you. So it saves you time in the office too. And the experience for the patients is much better. So it's a combination. It's a win for everybody. So thanks, sponsors.
All right, let's get to our guest. I'll do a quick little intro. Dr. Marc Pietropaoli. Dr. P, everybody's going to go with Dr. P. He's the founder of Victory in Motion, a #1 Amazon best-selling author. First surgeon in the world to perform a specific FDA-approved ACL repair procedure. We're going to get into all of that. He's treated over 30,000 patients, and his actual stated mission, is the need for knee replacement surgery by 2043. That's really specific, so I can't wait to get into that. Why 2043? That's not a tagline. That's a challenge. And today we're going to find out if you can back it up. Dr. P, welcome to the show. Thank you for joining us.
Well, thanks, Will. And thank you, Dr. Garcia. Great to be here. Greatly appreciate it. Thanks for the kind intro.
Thank you. Listen, let's take it way back. You're a third-year medical student, 1994. First day of orthopedic rotation. You walk into that OR. Surgeon looks at you and says, listen, knee cannot be repaired. And what were your thoughts? Were you like, yeah, okay, that makes sense, and let's just go about our day? Or was there a light bulb that went off in your head when you heard something like that?
Yeah, well, I think Grant, I think you'll appreciate this because, as a medical student, you show up, and I'm sure, I wanted to either be a fighter pilot, a rock star, or a sports medicine doctor. And my eyes weren't good enough to be a fighter pilot at the time. And I'd probably be, my parents would have never let me go into, a rock and roll drummer. I probably wouldn't be talking to you guys. I'd probably be dead or something. But I had to choose the lesser, and my uncle was a doc, and I said, I want to be a sports medicine doctor. He's like, well, you got to be an orthopedic surgeon. So I was like, all right, I'm going to be an orthopedic surgeon. So it was at the end of my third year of medical school, which, as you know, at least back then, it used to be you did all your clinical rotations. You finally got into that in your third year. So you're excited to get to see everything. And ortho was my last one. So I had seen everything else. I liked it. And then I find out the next day I'm going to be watching a knee replacement performed by Dr. Murray, who was the chairman of our department, but he's also one of the original inventors, David Murray, of knee replacements. He invented his own knee replacement. So I was all excited about that. Show up early. The junior resident's like, Mark, you're a medical student. You're not going to scrub and just kind of stand over in the corner there and don't touch anything, right? Don't touch anything. And then he says, but if you have any questions, feel free to ask. There's no such thing as a dumb question, right? How many times did you hear that in med school, right? So the patient gets wheeled into the room. I'm all excited. The nurses transfer the patient on the operating table. The anesthesiologist puts the patient to sleep. Dr. Murray comes in with the chief resident. They prep and drape. And then next thing I know, they're making this huge incision, and there's power saws, and there's hammers, and there's metal, and there's plastic, and there's cartilage and bone flying all over the place. I was super excited because my dad taught me how to use power tools because he put himself through college and law school. So I was like, oh, this is great. I get to fix people with saws and hammers and chisels and stuff. And then I looked at that huge incision. I was like, well, who would have ever thought to put metal and plastic in somebody's knee that it would actually work? But, obviously Dr. Murray did. And then I was like, this is actually kind of gross though. Like there's stuff going all over the place. I couldn't believe how like huge the incision was. And then I was like, it's kind of barbaric. There's got to be some other way. I was like a Star Trek. I liked Bones McCoy. He had the tricorder. You could look inside somebody and then you could treat them without, even cutting or needles or anything, kind of like an ultrasound and a laser nowadays, And so I remember what he said. He said, you can ask any question you want. So I raised my hand up and, he looked at me like, this guy's actually going to ask a question.
Oh, this is good.
No. And then the anesthesiologist is kind of looking at me and the nurses are glaring at me and, nothing happened. So I started to put my hand down and then Dr. Murray looked over his glasses. He's like, Mark, you have a question? I said, yes, Dr. Murray. Thank you so much for letting me be here. This is amazing. But my question is there any way to cure arthritis? Is there any way to grow back cartilage? Is there any way to repair a knee and not replace it? And before he could even get a word in, the chief resident points at me. He's like, there's no cure for arthritis. There's no way to grow back cartilage. There's no way to repair a knee and not replace it. So at that point, Grant, right, I knew that there was such thing as a dumb question, right? So I was very embarrassed. But yeah, Will, the light bulb went on. And I'm like, I'm going to figure out a way to repair knees and not replace them. I'm going to prove that guy wrong someday. And now, like you alluded to, 35 years later, I wrote a book. So Repair, Not Replace. And it all kind of stemmed from that embarrassing moment.
That's awesome.
That's your surgeon must have been like, oh boy, I got one of these. He's gonna be one of these difficult ones. I was thinking about you talking about being a pilot. I think everyone that saw Top Gun in the late 80s going to the 90s wanted to go into the Air Force or Navy and fly some planes here. So I digress. I do this, Garcia.
Also hard it's hard to make a sequel that was as good as I thought the sequel was great too.
It was phenomenal.
Maverick, yeah,
they're both phenomenal. That's funny you mentioned that. I mean, it's interesting. My first surgery was also a knee replacement, and it wasn't that level of aha. I didn't have any aha moments, so maybe I should have thought about this more. Clearly, you're on a better trajectory than I am. But nonetheless, the points you're bringing up are really interesting, right? It's like a lot of these things stem from early on when we do them. But what's even more interesting is how you describe that event. And Will was sitting there like, cartilage is flying everywhere. It's like power saws. Some of the audience members are going to be like, oh my gosh. And I'm like, okay, continue on. I like the details. This is awesome. So anyhow, it's just fun to hear those intro stories.
It's loud too, right? It's really loud in there. You don't realize how loud it is either.
Well, you don't if you're not used to it, right? To me, that's like my hum, right? I can that's like when I hear those sounds, those are what get me. Like I'm like, oh, I hear drill.
I just listen to AC/DC as loud as it goes, but other than that, we're good.
Yes. So talk about more about this. I mean, we can pull up that slide for Dr. P. But kind of go through this process with you. I mean, you talked about what you kind of thought about it. So explain this more and how you kind of developed this in your practice, because this is your practice, right? Up in, I think are you up in Buffalo or where are you up in?
Near Syracuse, New York.
Syracuse, yes.
Syracuse, yeah. Yep. So, well, Will, kind of to answer your question, Dr. Murray was one of the kindest gentlemen you can ever imagine. And I did feel as though I was going to get reamed out because he came up to me afterwards. And I was really nervous. I'm a third-year medical student. And he's like, Mark, that was a really good question. Sorry, he apologized for his chief resident. And he said, maybe someday, there's no way to do it right now, but maybe someday you'll come join us and you'll figure it out. So that really meant a lot to me. And that's pretty cool. That's right. I ended up doing my residency in Syracuse. And I'm telling you, we learned how to operate. Like, that's how you get good. So we did a lot of surgery, tons and tons and tons of surgery. And that one of the reasons I chose to go there is because the residents got to do a lot of the surgery. So I became very, very, very good at surgery, but we didn't get a lot of patient care and non-operative care or any of that stuff. We just heard, all these patients do great. And what do we know, right? We didn't even barely see them before or after the surgery. We just did a ton of surgery, rounded in the hospital, and then they were gone. So when I went and did my fellowship with Dr. Andrews, who is just, the most amazing sports medicine doc of all time. He just recently retired, but just an amazing man. And that's where I learned how to take care of patients. Everybody knows him, knows of him as a surgery operating on all these elite athletes, Roger Clemens, Drew Brees, saving his career, all these athletes, Tommy John surgeries. but he probably could have done 3 or 4 times the amount of surgery that he did. But he always, said a great surgeon knows when not to operate, because you can definitely get into trouble, as you know, right? And complications can occur. And he had a great physical therapist, Kevin Wilk, who's still working, Dr. Wilk. And, I would like 80% of the people Dr. Wilk and his team saw never needed surgery. And so these elite athletes would come down and they'd be like, I'm going to have surgery. And they'd be like, no, you're not. We're going to get you better without it. So that's kind of where I learned that. Even though he did like maybe 20 surgeries a day, he could have done 40, 80. He was just under very high demand. And Kevin, I would also say, because I learned surgery so well during my residency, I didn't have to do extra surgeries during my fellowship. We did a lot, but I also had time to go into the clinic and do a lot more clinic work, and also go into the PT. And that's where I heard you, Grant, talking about this in one of your videos, how it's such a team effort. And you have to coordinate all the different factions, the PTs, the ATCs, the strength coach, the coach themselves, the agent, the mom, the dad, the family. All these. So you really learn that. And, I learned a lot of preventive stuff down there. I learned about diet, and I learned about total body rehab. Kevin Wilk has some, he didn't just work on the knee, he's working on the hip and the ankle while the person's standing on a balance, and he's throwing balls at him and stuff like that. So I really learned a lot about non-operative and even laser. Like, I saw Kevin one day, I saw him waving this wand around on someone's shoulder. I'm like, what is that? A tricorder? He's like, no, it's a laser. I was like, what does it do? He's like, well, it increases blood flow. It stimulates the mitochondria. It helps with scarring. And I said, well, why are you going like this with it so fast? He said, well, it can burn the patient. And I thought, well, that's kind of dumb. Like, why would you ever want to do that? But further on down the road, eventually, that at least those things piqued my interest. I also, Dr. Bradley, who was the head team physician for the Steelers, Pittsburgh Steelers, he gave us a talk. We get these talks from all these famous doctors. And we all thought he was going to talk about all the surgery he was doing on the Steelers, but he was a huge pioneer in PRP, platelet-rich plasma, taking someone's blood, spinning it down, getting the platelets out, has growth factors, inject them in, and helping someone heal. He was doing that before a lot of other sports doctors were. And he came and he got up on stage and he's like, this is to a bunch of surgeons. And there's PTs and ATCs also in the room, but like the surgeons are all in the front row. And he says, our body has an amazing ability to heal itself. And I've been using patients' blood to help them heal. And like the whole surgeon row was like, what? This is stupid. I'm never going to do that, And they had they had a demo where the reps came and you could go do that. And I was the only resident, the fellow who showed up. Like, there was a couple PTs and myself. And I had my patellar tendon was killing me from running the Boston Marathon the year before. And so I actually got it probably wasn't PRP at the time. It was probably mostly blood, but it hurt, but it worked. And so those are the things that were the foundational principles that kind of made me realize that, that you can get people better without surgery. And then even if you don't, you get them in the optimal condition before you do the surgery, they're always going to do so much better. Like, prehab was a word down there way before it was anywhere else. And, I heard you talk about, like, that, was it the recovery story you were just talking about? Or
recovery shop,
right? That stuff is getting people nutritionally in shape, getting them ahead. I've heard you talk about PT, going to PT ahead of time, getting all that range of motion back. All that stuff leads to better results, but a lot of times it also leads to no surgery, which is fine. I've had 5 surgeries. Who wants surgery, if you don't need it? So then my dad got a infected hip replacement 10 years after his hip was in, and the infection wouldn't go away. They had to open it up. It looked like a shark bite, a huge wound. And they had to just let it heal from the inside out, which is very difficult. And, within a year of that, he had pancreatic cancer and he passed away. So to me, that was kind of like, I had the idea in 1991, but, that's when I decided I'm going to do something about it. Cause I knew at least 25 to 30% of joint replacements are unnecessary. Several studies have shown that. I think it's even higher, but if you look at the studies, so that's kind of how I got on this path.
Well, I think that's a good point you bring up. There's a lot of stuff we're going to ping about each thing you talked about, But I was just talking to Will before you came on and before we started this show that the important side of this is that we're talking to an orthopedic surgeon, does lots of surgeries, knows a lot about surgeries. But at the same point, the non-operative stuff's a big deal. But stuff we didn't learn in residency. Same for me, it was fellowship at Rush with Cole, and he sees so many people that don't need surgery and treats them well. We've had him on here, and he's talked about that as well, right? Like the surgery is the sexy stuff, but I've had multiple patients today came in, they're like, and number one thing, actually, many of the patients, since I do cartilage preservation, come in asking, they said, how do I avoid a knee replacement? So there's this sort of underlying thing. And a lot of the patients you come in and see you, I'm sure you have the same thing. They were told by everybody else they need a knee replacement. And so sometimes there are alternatives to especially total knee replacement. So it's every ways approaching is really interesting. And again, you have patients, like you said, there are patients that need this knee replacement, but there are a lot that don't. And it's a really quick, easy fix for someone that doesn't have a lot of cards in their deck, right? Which you can go into. I mean, what's your experience in the office? I want to talk about all the stuff you're doing, but your experience in the office of these patients that, hey, they've got a little bit of something, maybe a little bit of arthritis in maybe one compartment, and they're kind of like knee replacing because it's the easiest, fastest thing for someone to get the patient done. How do you approach those scenarios?
Well, now I approach them differently than I did maybe 5 years ago or even 10 years ago, because I was in the insurance world of healthcare, and the last 3 years I worked my way out of that. And as of January 1st, 2025, I've been completely out of insurance, which is a very rarity that's a whole nother show. But so I handle it differently now, because I think people come to me because they now know that I don't do when COVID hit, I mean, you want to get into another catalyst. So I was doing knee replacements right up until COVID. When COVID hit, and I was doing PRP since 2008, and I was doing bone marrow since 2017 and laser since 2017 and the nutrition. So I had all these kind of pieces that I did, but I always kind of dreamed of putting them together as a program. But I was just afraid. First of all, I was afraid of my own colleagues, like being labeled a quack, and I was afraid patients wouldn't do it because, let's face it, insurance doesn't cover, most of this stuff. And because it's your own body healing yourself. And so when COVID,
they cover knee replacement, but that's about it.
Yeah, for like $30,000 to $60,000 total dollars out of the insurance industry. But anyway, I had patients who were scheduled for knee replacement and patients who needed one. And they were like, what are we going to do? And I said, remember all those things we talked about? Like, why don't we put them together? Insurance was paying for telehealth, which I think is one good thing that came out of COVID. There's some good things and bad things that, something good always comes out of something bad. And even this, this has exploded, Zoom calls and all these different, this tele stuff. So I said, we've gotten that approved. Let's put this stuff all together and ask your insurance company if they'll let us do stem cells and PRP and laser. And, because you can't have surgery right now. We don't know when the ORs are going to open back up. So we put it all together, sent it to the insurance company, and they were like, yeah, you can do it. I'm like, okay, well, are you going to cover it? Well, we'll tell you after the fact. And yeah, we couldn't get around that. So I had some brave patients. Bill's one of them, who's the first chapter in the book, but I had several patients who decided to do it because they were in so much pain. And honestly, I mean, I know you've dealt with biologics, but isn't it it's so amazing when someone gets better and you're like, I don't know, all I did was take some cells, concentrate them and put them and like our bodies had this amazing ability to heal ourselves. And it blew me away how well these people were doing. Meantime, so within 3 months, they're doing pretty amazing, these people, with these programs that and we can't forget the total body fitness part of things as well, the rehab, whatever you want to call it. And so these patients were doing well. We went back and forth with the insurance companies, and eventually they said, no, we're not paying for it. So I have to go in the room, 3, 4, 6 months after they paid money out of their pocket and say insurance didn't cover it. And honestly, not a single person was upset. They were like, I figured that. And like, but I don't care because I didn't have to miss work. I didn't have an incision. My buddy had surgery. He still can't kneel. And I'm like, I'm onto something here. It's not just a shot. It's not just a laser. You put these things together, they work synergistically. And it came down to developing programs and systems, just like anything else you do. But it came down to doing programs and continually refining these with my team.
Will, I want to pull up it. Will you pull up his slide, the Clarity Day thing? Maybe we can talk about that. So is this something, can you talk about this a little more? I mean, this is obviously, you told us where it stemmed from, but this day of like, how do you get that evaluation done?
Sure. So, well, first of all, that cycle of insanity there, I think the first patient in the book, his name is Bill. His wife actually got him to come in. He didn't trust anybody, but he was like, I told him, I said, what, I have your old records. I looked at him, but what happened? And he's like, well, it's insane. It's insanity. So I was going to call it Bill's cycle of insanity, but every patient, we're all patients, right? We've all been through this as a patient, right? You say you have knee pain, you got to go see your primary care. They don't have time for it. They're going to spend 10 minutes with you. They're like, go take some Tylenol, whatever, and see me in 2 months. You come back in 2 months, your knee's still killing you. They're like, okay, we'll get an x-ray. But you have to go down the street to the imaging center to get the x-ray. They won't give you the results. You have to wait for your doctor to call you. You wait a couple of weeks. Then finally the doctor might call you or someone, and they're typing on the computer looking at a report. They never look at the x-rays. Oh, You have arthritis. We're going to send you to an ortho. And in his case, he didn't want to see the same ortho who had operated on his shoulder and told him he had a rotator cuff tear, and he didn't have a tear, and his shoulder was doing worse. So he didn't trust me at all. I didn't even do his surgery, and he didn't trust me. And so they said, he actually got referred to a different ortho before he even saw me. That was 6 weeks. And then he says, well, if you're going to tell me I'm going to do surgery, I'm going to leave. And the guy's like, well, we can't tell you that anyway. You have to go to PT first for 6 weeks, twice a week. And he gets to PT. He actually had both his knees and his shoulder were killing him. And they said, Bill, what's going on? He said, well, both my knees hurt, my shoulder. They said, pick one. He's like, what do you mean pick one? Pick one, because the insurance only lets us take care of one thing at a time. And we don't have time to take care of all three anyway. So his knee didn't get much better. His other knee and his shoulder were killing him. Then he got the cortisone shots, which worked. But then his wife looked it up online. Is like, cortisone's bad. So he goes back and reams that guy out and says, I don't want cortisone. He gets the hyaluronic acid, the quote unquote gel injections. He's told they're going to last 6 months. They only last 3 months. Then he demands an MRI. The insurance only approves the MRI for the right knee because that's the only one he had the PT on. He waits 4 weeks to get the results, and they told him, you have arthritis and you need a joint replacement. So he's like, what if I don't want one? They're like, well, then you're going to have to suck it up. When your pain gets bad enough, come back and see us.
Yep.
And so you get two options, either do the replacement or suck it up. And there is a third option, and that's, let's figure out what's really wrong and try to treat the root problem and, repair the knee. There's ways to repair. Even people there's people who just don't want surgery no matter what. And you would never think someone whose x-ray looks so bad, you could actually get better. But that's where the underlying thing is that a lot of times it's in the bone. And arthritis, you get these bone marrow lesions, which are actually stress fractures. They're little microfractures. Yep. Bone has millions of pressure-sensitive nerve fibers. Most of the pain comes from the bone because the articular cartilage, the tread on the tire cartilage, doesn't have any nerve fibers. So that's what he ended up having. And that's what we were able to actually inject. Because Dr. Hernigou, a great study, he had 140 patients. He's a French orthopedic surgeon. And just to make it quick, he basically did a knee replacement on one knee, and he did stem cells on the other knee into the bone marrow lesions, into these stress microfractures. And he followed these people for at least 10 years, which is amazing because most studies are like 2 years, a year. Everybody's doing great. So 10 years. And by the time the study was over, 15 or 20 in some patients. So the average follow-up was 15 years. At the end of that study, these are people who were told they needed knee replacements. 82% of the knees that just got the bone marrow only into the lesions, not even intra-articular, they never needed a knee replacement, and they felt their knee felt better than most of them felt their knee felt better than their knee replacement knee. And then 15% of those knee replacement knees needed a revision. And revisions they're harder surgery, don't last as long, there's more risk. So point is, I was also frustrated with this cycle of insanity. We've all been through it. It took Bill over a year to get through it. So I just said to myself, if we figured all this stuff out in one day, yeah, you're doing an MRI right away, you're doing an ultrasound, you're taking your time with patients, you're spending 4 or 5 hours with them, but you can figure it all out in one day. And in my mind, it's way more cost effective. I don't know why the insurance companies don't do it, but I think it's because people quit along this cycle of insanity. Bill made it through 54 weeks. They probably lost money on him, but some people quit when their primary care tells them, I don't have time for you, or they quit when they know they might need surgery. I'm not going to go see an orthopedic surgeon. So they suffer in pain, or, they do the PT. It doesn't work. They give up. I'm old. I'm never going to get better. So we basically, we spend, I'm able to, now that I'm not in insurance, I can spend as much time as I want with a patient. I'll spend an hour with them in the beginning of the day, and then we'll look at all their old records, go through everything. I'll actually do a physical exam on them, which I know you do because you did an amazing fellowship and residency program. But a lot of docs, they just throw the x-rays up and say you need surgery. They don't even, how many patients tell you this is the first time someone's ever examined me? I'm sure you
surprisingly get it more than you'd think.
Yeah, it's
they
amazing.
were like, oh, you looked at my, or you actually looked at my images?
Exactly.
That one I get a lot.
Or showed them to me. So
that's
we go
next level. That's I don't want to overwhelm them sometimes. I give them at least the exam and the but yes, they get the same.
You probably don't have the, it's not your fault and wasn't my fault when I was seeing 60 patients a day. You don't have time for it, right? 30, 40, 50, 60 patients. It's crazy. So we slowed it down, get all that done in a day. People do have to invest in it. So the insurance covers some of that stuff. If I'm a non-participating provider, they can still submit the MRI codes and things like that. But when it comes down to doing the PRP and the bone marrow and all those things, the laser, that's not covered by insurance. And people know that. At the least, though, at the end of the day, they know exactly what's wrong with them. It's been explained. We've showed them everything. They know how to read an x-ray by the time they leave. And we spend the time with them, try to figure out what their actual goals are. As a sports medicine doc, we do that a little bit better probably than other docs, only because with an athlete, you do have to know what position do they play, what level they're at, what's their time frame, what is their contract like, all those different things. You really do have to sit and listen. It does take longer to be a good sports medicine doc. So I think that's where we have a bit of an advantage. We have to listen. We have to go the extra mile. And so I just took that to the next level with everybody. And Dr. Andrews always, he treated elite athletes, but he always said, we treat everybody like an elite athlete, whether it's a grandma or a mom or a brother or sister. It doesn't have to be an elite athlete. You treat everybody that way.
No, it's an excellent point you bring up. I think there's a number of points you brought up. Obviously, we'll talk about that cycle, the treatment options you're using, but I think one of the things you're doing that we can't do right now, many of the doctors, as you mentioned, is the holistic approach to evaluation of these patients, especially with, my knee hurts and takes some months. I mean, the thing is also I'm not saying all your treatments are perfect, but sometimes there's also a little placebo effect of you just being available and listeing as well. There's a combination of everything.
Mental, you talk about it, right? The mental, you said one of your podcasts, you said it's at least 50%, especially with athletes, right? So when someone finally commits to a program and they do have to invest their own money in it, they are committed. And so they're committed. B, there's always, even honestly, some of the surgeries that are done on athletes, there's a placebo effect as well.
Oh, I've seen images of some ones that do not work very well. Right. Have not gone well. I mean, I'll never forget. I saw one of the Hall of Fame twin player for baseball team, I mean, a nameless, with an ACL allograft at 25 years old, unstable knee in my examination during the White Sox. And he was saying he felt amazing. But I had to check it out. So I went with a doctor to kind of look at it. I saw the x-rays, vertical tunnels. I'm like, you know what I mean? This is a guy that just is a different level player, right? Did not have a good setup and they still did well. Right. So it's like you said before, there are plenty of times we see patients have had surgery, especially these athletes, where the result wasn't good, but somehow they're still doing well. And it's just the nature of the beast. But like I said, there's a placebo effect. There's also an effect of what you're going to get to in a minute is the alternatives, right? Like the PRP, the bone marrow aspirate's important aspects. But what about you talked about, you'll show this. Can you pull up this V-Slim thing? I want to learn more about it. So there's a part one part that's really interesting about knee replacement, which I think you're going to bring up, is there's some patients that don't want to lose weight, do nutrition because they just don't want to do it. They're not invested in it. So if you're getting patients to already do that, that's already a part way there that most docs can't even do.
Yeah. And you have to have time, right, to educate them. So that's the thing. So, I mean, Bill was a gardener and I'm a gardener. So that's kind of where this gardening analogy came from. But, I asked him it's springtime. So right now you go out in the garden, you're going to rake out all the bad stuff. You're going to pick the weeds. He said I would take a weed eater and get rid of the weeds, and then I would put topsoil down. I said, well, what is I said, why do you get rid of the weeds? Facetious question, but why do you get rid of the weeds? He said, well, because they choke out all the other plants. I said, well, inflammation does the same thing, and fat causes inflammation. And I said, well, what about the topsoil? And he's like, well, it has, there's no weeds in it and it has nutrients. I said, well, how do you get your nutrients? He's like, well, from my diet. I said, well, how do you know what the right diet is? He said, I don't know. They tell me to eat more protein. I said, well, the only way to really know, and this took me a while to get this figured out too, because I had a lot of different dietitians and nutrition people, and they all have their own take on things. As you know, they focus on one thing, and it's not necessarily wrong, but one size doesn't fit everybody for nutrition for sure. And your genetics are the huge thing. That's the kicker. So it's a simple mouth swab. You get a 32-page report back. It tells you, what percentage of fats, carbohydrates, and proteins, but then it goes into a lot more detail on your micronutrients. It goes into the vitamins, the minerals, any sensitivities, allergies, even exercise. What's the best exercise for you? It just so happens I like endurance events, but I didn't know that was my genetics. And it turns out that's what my genetics actually is. So we can figure a lot out from people's genetics, and it can be a lot more specific. So the weed eater part is a little different. Laser therapy that Kevin Wilk I was talking about that's more of a healing laser. Slide. Yeah, that's more of like a class 4 laser, and that stimulates the mitochondria, which, okay, Will, do you know what the mitochondria is? You remember from high school biology?
Mm-hmm. And also, I'm a doctor on this show.
Powerhouse of the cell, baby. So it stimulates that mitochondria to produce more energy, and it releases nitric oxide, causes increased blood flow, decreased swelling, decreased inflammation. The cells work better because they're producing more ATP, and also it has a direct pain relieving effect, inhibiting the nociceptors, the painful nerve fibers. And I didn't necessarily think it was true either till I tore my calf muscle running in a marathon and just messed it up, and it bothered me for several years. And then somebody said, hey, you want to try this laser? And this actually happens to be an MLS laser, multi-wave locked system. So there's 2 wavelengths of light that are locked together. And unlike the one that Kevin Wilk used, this one cannot burn you. It's patented in a way that you can shine that on somebody all day long and it's not going to burn them. Okay. So it basically got my calf better when nothing else did. And then I was a total believer in it. And I've had had some version of laser. Actually, I even have a handheld laser right here. It's not the same power, but it really is amazing how light energy can help, and that's called photobiomodulation. But there's other light energy, red light laser, which is maybe 600 and something nanometers. That laser can cause your fat cells, the pores, to open up. It actually breaks down the layer around your fat, and then when that breaks down, then your cells really, the fat cells release it. It goes into lymphatics, and it's either used for energy production or you just eliminate it in your you breathe it out or you pee it out or poop it out. So, but it decreases inflammation in fat. And then the side effect is it also decreases weight and decreases inches. So it's pretty crazy how light energy can help with all those things. So to your point, it's really hard to get somebody, convince them that they're going to lose weight and get on them, even if it's genetic diet. Like, it's going to take time still. So these red light lasers, the one that you showed before, people will lose.
Is that this one?
Yeah, I must not have sent you the picture of it, but it looks just like it's almost like a tanning booth. It's a red light laser. It's a kind of, rectangular, maybe 25 by, 12 inch, red light laser display, and people lose about 3.5 inches of fat per treatment. Now, I always tell them, if you go home and drink beer and eat Twinkies, you're gonna gain it all right back again. You're gonna fill your fat cells back up. So my point is, it gives them quick wins, and when they see those quick wins, then it's a lot easier to get them on board. So if that makes any sense, sometimes we'll give them a treatment, and just to show them, 98% of people lose at least 2 inches. You measure them, or we take pictures, and they lose weight. We don't want someone getting laser treatments for the rest of their life. That's where the genetic part comes in. But at least get them a quick jump start. And the diets are amazing. They're anti-inflammatory. It's real food, but it's what your genetics allows you to eat to keep your inflammation in your body down.
And you're providing all those services. So you do the red light therapy. You also do the MLS one, right? Because it's
yes.
And that's the one that they recently had the AAOS recommendations on, the MLS.
Correct.
Can you describe that a little bit to the listeners?
On
the suggestion on laser for pain and pain and inflammatory modulation.
The AAOS, I think they said just photobiomodulation by itself, or laser therapy. MLS is a certain brand, but there's a bunch of other lasers, brand name lasers out there as well. But yes, it did. They have now said that it's a viable recommended alternative, and there's enough science behind it that they could recommend it as a non-operative treatment for pain relief, decreasing swelling, inflammation, and pain.
And do you use that? So are you using that? So you use the nutrition, obviously, is a big combination. Clearly, you need a genetic evaluation. Then you have red light therapy for weight loss. Do you ever integrate in GLPs anymore now, or is that not part of the regimen yet?
I've tried to get people off meds. So a lot of people who lose the weight, et cetera, they get off the meds. I'm not saying that I don't coordinate with other docs who do the GLPs. GLP-1s. I don't have a problem with it if someone really needs it, but we've had a lot of people not need them, and they do have their side effects. And a lot of some patients have already tried them and didn't like the side effects. So I'm not saying they're necessarily bad. Some people really do need them. And there's a lot of, we could get into peptides and all that stuff too. There's a lot of stuff to go there, even hormone therapy. I mean, you can really go down a lot of rabbit holes, but we're a whole person. Everything affects everything else. And that's where medicine we've gotten so specialized and compartmentalized. We just treat, if you just treat the knee and that's it, and they have a tight hip flexor and their back's got a problem and they have a tight Achilles tendon, even with a knee replacement, those people have a lot of soft tissue pain still. 30% of them still have some soft tissue pain because that wasn't addressed. So your goal here, and then so that you're doing this treatment regimen, so how long is the process? Someone comes in to see you, you're working through this, I know you said you do it in a day, but I'm sure there's some caveats to that. So explain how it works. Sure. The clarity day is all about diagnosing and figuring out what's wrong and coming up with a plan or giving them 3 options. And some people, if I can't help them, I'm not going to abandon them. I'm going to get them into who I know does a great knee replacement, or who does a great back surgery or whatever, if they need it. Or if they have an ACL tear, if they have a rotator cuff tear, if they have a loose body or unstable meniscus tear, I still do surgery as well. So some people still need surgery, but that clarity day is about figuring out what's wrong very quick, within a day. After that, if they're going to start a regenerative program and they're going to do all those components that you kind of showed there, that's going to take probably a good 12 weeks. It's about a 12-week program. First 3 days, I had it done on my elbow. So I had a really bad common extensor tendinosis, quote unquote, tennis elbow, but 12 years worth of it. So I said, I'm going to train my PA how to do this. And then his graduation is going to be, I'm the first one he's going to do it on. So he did a great job, and he's done. No pressure. Exactly. He did great. He's amazing. So I had it done on my elbow. So the first 3 days, because we're trying to kind of restart the healing process. Most of these degenerative conditions are because the body's healing process is kind of slowed down or stopped for many reasons. And so we're just basically trying to restart the healing process. So I always tell them the first 3 days, you're going to be pretty sore. We're kind of re-injuring, let's say it's a patellar tendon, or even your common extensor tendon. You do have to kind of poke in there with the needle and kind of stimulate and break up the tissue and inject your PRP and or stem cells in there. And so the first 3 days are pretty sore. First 2 weeks are the most restricted. After 2 weeks, I felt amazing, and I started to overdo it, which a lot of patients do. So that, you're still, I think Dr. Buford says it best. I think that you're basically starting about at the 6-week point after a surgery when you do one of these regenerative procedures. That's you're 6 weeks into after a meniscus, not repair, or, partial meniscectomy or some surgery, a rotator cuff, a subacromial decompression, a chromioplasty, something like that. So that's kind of where your starting point is. So you're not as restricted. And then I'd say the first 6 weeks, by 6 weeks, most people are feeling 50 to 90% better. And then at 6 weeks, we really start getting the total body, really going, getting them into whatever they want to do. Some people want to hike a mountain. Some people want to travel. Some people want to play with the grandkids. Some people want to play pickleball. We really like to know what their top 3 goals are. And then we design a plan that fits with that. And that's where having studied under Kevin Wilk, and then my PTs and my ATCs, et cetera,
Yeah.
they are all strength and conditioning specialists as well. So they have a medical degree, they have a fitness degree, and they just, they're amazing.
I think that's an important point. I actually bring this up a lot. I really like you to said that. That's good for the listeners to hear. When patients go for PT, it's good to have a physical therapist. But when they get to the next level, the strength conditioning side, I don't know what different, it might be different certification, but I think of ATC, like really like high level knowledge training. That doesn't happen all the time for patients. And so they don't understand there's a difference, but there really is. And
Huge.
Will, recovering wise, you know this for firsthand, but like there is a difference. And I tell patients, if you can't find it, you got to pay for it because it's sometimes hard to find. But that's, I think in you're bringing that up, that point is that it's just, you really need that next level. And sometimes it's not the just bands and pulleys and medicine balls. It's more than that. There's a lot more that goes into it.
Absolutely. And I mean, some of these people, especially the ladies, 60, 70, 80, they have only walked for exercise their whole life, if that. And when they hear they have to do resistance training, et cetera, at first they're very resistant to it. But once they, studies have shown people in their 70s, 80s, 90s greatly improve with resistance training, confidence, less, better balance, less chance of falling, building muscle mass, bone mass. And they get so confident that, okay, their goal was to walk their dog and go up and down their stairs without pain. Next thing you know, they're like, oh, I want to dance at my grandson's wedding, or I want to start taking dance lessons and start dating again. It's amazing the confidence that they get from exercise. So I have one lady, she's 89 and she's probably been in for 250 or more strength and conditioning sessions after she got better from her program. And if you look at her knees, you would be like, oh my gosh, these things need a knee replacement, but she doesn't. It's amazing.
Well, I think the point you're bringing up, and we'll probably ask some questions, is that not only does not everyone need a knee replacement, but the other side of thing is that we're all doing, as surgeons, not doing a great job of titrating all the outside factors. Whether you want to talk about bone marrow aspirate, PRP, there's definitely benefits of all those things, and even the laser and things like that. But like the basic things, we're just not doing a good job. So you're already beating the system because you're tanking up all the simple things, which is not saying your job is simple, but simple things that we're missing and we have no time for that are straightforward. And like, also that 89-year-old patient, she's going to PT. They're not giving her very much time and energy because insurance brackets, et cetera, and they don't have time either. I mean, no offense to physical therapy. It's the same problem, right?
Yeah,
the problem is systemic in medicine.
Totally agree. I mean, diet and exercise, it sounds cliche, but it is massive. So you're right. It is simple. It is something that the ancient Greeks knew. Like everybody's known this, right? But we don't do it. But when you do,
it's not a quick fix.
Yeah, and when you do it, it's an amazing, life-changing thing.
And so I like the idea. So you basically now your practice, obviously you do some of the sports stuff and you do all this thing. Your whole practice now is like holistic, whole body kind of fixing of the person, looking more outside. And I always say that, like, you don't want someone that's going to just talk about your knee, right? Tell me about your hip, tell me about the rest of your body, nutrition, background. I mean, it kind of comes together with things we've talked about, Will, on this show. I'm sure you have a question or two. I can see your lips moving. You're ready to rock. What question do you have for Dr. Pietropaoli?
No, I think obviously there's so much that resonates. And I just want the listeners to really focus on, besides everything you're talking about, but the physical therapy, the resistance training. I know for people that train in Strong First and Pavel, they talk about simple stuff, right? The get up, right? And they're saying you don't need to load. It's just a basic motion for you to get up off the floor, right? And it's these simple trainings, the hip, the hinge, the squat, for you to operate and move throughout life. And I think that's something that even if you're, taking something out of it as far as keeping that movement, you're talking about diet, all of these different therapies. And I have a question real quick on that as well. But this is why we talk about not just physical therapy, but moving so you can have a quality of life. And if it's just picking up your child, your grandchild, getting up from the chair, getting out of bed, right? I remember when I was injured, I went back to my kettlebell training. I was like, I'm rolling over to the elbow, to the palm, push myself off the bed, swing my legs around, like basic stuff.
Awesome. Motion is medicine. And I changed my name from Victory Sports Medicine and Orthopedics to Victory in Motion. So motion is big. You just hit the nail on the head.
We want to talk, Will, I know you want to jump on this, but we want to make sure we have enough time to answer this question. Explain the goal endpoint of 2043. I'm assuming you're not going to be retiring then. So
that's the way we started the show, right?
I know, but you never finished. You never finished the question, and we're running out of time.
Teaser. We're getting to the end of the show. Then we get back to 2043.
Well, so first of all, I've run 7 marathons, and if you want to achieve a goal, you have to say what you're going to do and when you're going to do it by, and you say it as many times as you can and as to many people as you can. And so the first phase of knee replacement free by 43, which by the way rhymes, so there's your spoiler, okay? But it's gonna. I knew it would take about 20. It's gonna probably take 20 years to do this, and I might retire from operating, but I'm not going to retire from that goal. And if we can put, I'm watching the lunar flyby right now. I mean, if we can put a man on the moon by in 1969 with 50s and 60s technology, there's no way we can't end the need for knee replacements, which by the way, right now it's more about getting the word out that there is a third option, but it's even more important by far. And I've heard you talk about this as well. And I know how hard this is because you both talked about it, but getting prevention, right? That's the biggest thing. A lot of arthritis, a lot of our diseases are preventable, and ACL tears are very preventable, 50 to 75% with the right programs. We've run those sports metrics programs for years, and it's not easy to get convinced parents, et cetera, and kids that you're better off investing a lot less money in saving your knee from a non-contact injury, especially females, than you are investing in all this equipment and getting in 3 leagues and getting in every indoor tournament you could possibly do. They spend so much money on that, and then the kids get hurt from overuse, because I've heard you guys talk about that, and you're ahead of the game on that. So anyway, I outline it in the book, but I think the 2 biggest things to really get to knee replacement free, maybe 3 things by 2043 is, number 1, getting the word out that there are other options and getting people excited about it. Because I'm not going to do this by myself. I want to get, hopefully we work together someday on this and we keep getting more and more people involved. Because a lot of people, even orthopedic surgeons I know, who are getting more involved with this type of thing. So getting the word out to patients. Most patients have no clue there's any other option than knee replacement. But then preventing, that's a huge thing. And then the advances in regenerative medicine and AI and 3D. I mean, with the cartilage restoration you're doing, there's already been massive advances there. And with 3D printers and scaffolds and all this stuff, that's all going to happen. And I was just in Dubai before all the shooting went on, and I was at a conference and with docs from all over the world. I mean, we can't even do so many of the things in the United States that are being done in other places in the world. And that all that stuff's coming. So that's kind of the technology phase of things. But prevention, I still think, is number 1. That's the hardest one of all. But that is, a lot of this is preventable, and the right diet, the right exercise, all those things, you can prevent arthritis a lot of times. I mean, there's some genetics to it for sure, but you can prevent the need for knee replacements by doing simple things, as you said, but simple's not always easy. Sometimes 100%. Simple things are the hardest thing.
100%. Will, pull up that slide. Let's give him one last punch. So again, big shout out, Dr. P's book. He already kind of gave us the headway, but there's way more nice details on the inside. So any last plugs for your book here?
It's written for patients, just so patients know this. So it is written for patients. It has a bunch of real patient stories in it, real names. These are real people who've been through this, including myself, all my experiences. And so a lot of what we talked about is in there. There's some free stuff that you can do on your own. Drinking water and moving more, right? Those are 2 easy things to do. less sugar, cutting, so they sound cliche, but they do work. And so, and then when you do buy the book, $1 of every book goes to the Arthritis Foundation. We're trying to raise $1 million to at least get the word out there to start with. We're going to need to raise more than that, but we're going to start with $1 million and go from there.
Awesome.
Dr. P,
any final thoughts?
One quick question here. With everyone's technology, we now have the power in our hand to look things up. Are you getting patients that are coming in more informed or less informed with the amount of technology that they have now and access? Are they already coming in with a certain goal and you're just kind of shaping that goal in 2026?
Yes, for sure they're coming in, but it's been an active process. I mean, myself and a lot of other regenerative medicine docs have been getting a lot more word out there. I mean, anybody who reads my book, they come in and they're much, much more, the appointment goes much better because they've already read it. It takes 4 or 5 hours to read, and the more informed, I think, the better. And frankly, I welcome them to bring a spouse or a loved one or whoever. we pretty much demand that they bring someone with them, which is so hard to do when you're in traditional medical practice. You don't have time you just don't have the time. The average time a doc spends with a patient nowadays face-to-face is like 7 minutes, 8 minutes. It's crazy. Not you though, because I know you're a good sports medicine doctor, but
yeah, sometimes it's hard.
It is.
There's no way around it. I mean, you definitely have a nice setup there, so that's great. Well, thank you so much for coming on. I think Will feels the same way. We're excited to show this.
Yeah.
Let listeners know there's another side, there's another option, and promote the book, etc. So anything final, Will?
No, just obviously I have lots of questions, but we'll get into that another time. We talked about a lot of different things, and I'm curious about arthritis and what the technology is going to be. That's the big one that we always talk about in these shows is, getting to a point that we can kind of, say goodbye, and arthritis is a conversation for another time. But Dr. P, thank you so much for your time and your patience. This was really informative. I know that patients and doctors alike will really enjoy everything that you said. So thank you so much.
Well, thank you, Will, and thank you, Dr. Garcia. You guys are doing a great job spreading the word, and I love your show.
Thank you.
That's Dr. P. He was on we have to send him a check for that beautiful plug there. So the check's in the mail, Dr. P. Thank you so much. Going back to what we said, there's just so many things. I was a BP 157 and this and that, and
don't even get started, Will. We have to have another episode on this. You always do this.
The wheels are turning. I've got things down. I've got a whole booklet full of notes, and
I knew it, but I had to cut you off because I knew you were going to ask me 15 questions, and then we're going to be here all night, and we have to be rude and cut him off. Then
no, we're not going to do that. But we want to remind everybody, catch us out. sportsdoctalk.com. We are on YouTube, your favorite listening platform, where there's Apple, Spotify, iHeart, Google. I mean, I was checking in some random places. There went the show. So we just want to thank everyone, and please go check out the website. We have transcripts. We want to hear from you. We want to hear from new guests. We just want to keep spreading the word. We want to talk about these things. We want to have real conversations. It's really important to us, and that's really kind of why the whole reason that we got into this, right? A platform for us to talk and get into things that really matter. And I think having a guest like Dr. P really matters. So Dr. Garcia, our orthopedic surgeon and sports medicine specialist, you keep rocking it. I hope you have a great one. Thank you for spending some time with us. Do you want to say some last words here?
Yeah, I mean, you just noticed with the show, the nice thing is we always have different perspective, which is key, right? You got to see everything. I always tell the patients in the office, get multiple opinions, get different sides of the story, and pick whichever works best for you. Some patients, again, different methodologies work for different patients, and you just got to find the right patient for each thing. But there are everything works for somebody. And so just find what works best for you. So thank you guys. Thanks, Dr. P. And check us out.
That's right. Be like Dr. P. Ask questions, even if they look at you weird in the operating room. But that's the way how we get to all this stuff. And do me a favor. I thought you were going to go with the Will cycle of insanity. We're not using that phrase. Okay. So just stay away from that. All right, everybody. Thank you very much. Take care.
Bye.